Welcome to Global Medical Office Dialogues. The U.S. Social Security Amendments of 1972 extended Medicare coverage to individuals with end-stage kidney disease who need either dialysis or transplantation to maintain life. In this episode of Dialogues, I talk with noted medical researcher and economist, Dr. Philip Held, about the 50th anniversary of this landmark legislation and how it changed the trajectory of kidney disease care in the United States and beyond. Welcome, Philip.
Thank you.
Let's start by just take us a little bit back to 1972 and what was the environment you remembered when Congress actually enacted and provided coverage for end-stage kidney disease? What do you recall about that time?
Well, it's interesting. I was in my last year of graduate school at Berkeley, and I, of course, did not know too much about this field. I do recall that someone dialyzed before a working session of Congress. And as I recall, that was a very influential event. What this bill did is, which was quite striking, is the sense that there were no age restrictions on the coverage of this care. And even to this day, I still find people who are shocked when I tell them that Medicare covers all kidney failure problems, regardless of age. I mean, people are so set in this notion Medicare is this program for the aged. Fundamentally, what Congress said was this person is disabled for purposes of the Social Security Act, which of course rolled these people into Medicare coverage. And I don't think there was a lot of knowledge that that's how people got into Medicare. There were three ways of getting into Medicare. One was the aged, which everybody was well aware of. There's a program for the poor, and then there's a program for the disabled, which is where this came from. Those distinctions ultimately did lead to a lot of complications in terms of when someone was less than 65, but they were in Medicare. I will say that a couple years later, I was at Northwestern University, and Medicare, or the people at Medicare, asked Mark Pauly and I to write a 2-page memo on how Medicare should pay kidney doctors. We wrote a 35-page paper.
I was going to say, that didn't sound like a 2-page question. Let's put it that way.
If there was a central theme that was a shocker in our paper, is that we encouraged the government to think about paying, in some sense, not fee-for-service, but in something that related to outcomes, how well things were and so forth. No, nobody paid any attention to us, except maybe someone who preceded you. And so we wind up in Boston at the Office of National Medical Care, and we gave a little presentation. After our meeting in Boston, which we were quite taken back that Gus Hamper's he clearly had read the paper and was interested in it. What I do remember most, again, going back to this 1972 period, extending this insurance coverage was not widely supported in the nephrology community. In fact, the editor of the New England Journal was very explicit in saying, this money should go to research to find a cure for the kidney failure and so forth. And he didn't say it was a waste, but in effect, he was saying, let these patients pass away. And anyway, there was a considerable hostility at that time. And that basic hostility, interestingly, came back years later when I was dealing with the NIH. And, they've done very few clinical trials. And the basic scientists at NIH were very hostile, or many of them were, to NIDDK doing a clinical trial. And as you recall, actually, Ed Lowry he was very involved in the 1980-some trial, which was looking at adequate
dosing of
an
dialysis.
aspect
Yeah.
of dose. And the reason they were so hostile is because this trial was taking away a lot of money from their research grant applications. And they just thought that their basic science was much more important than doing a clinical trial.
A few years after the public law got started and there was this recognition that the government wasn't going to build facilities and do this, they were going to let private business do this, they realized they needed to expand the way they oversaw it, and they developed the end-stage renal disease networks and then subsequently the USRDS. You want to just give us a little flavor of what that time was like?
At the time, we were quite surprised, Mark Papoli and I, that we were invited to write this paper on how they should pay the physicians. I would say that it was pretty explicit at the time that the big thing that was changing there was going to be this for-profit notion of institutions offering dialysis. And it was the building of trouble that I would frankly say has not gone away, in the sense that I might add that the first thing that became apparent is that these private, many of them for-profit organizations, did a wonderful job in terms of what Congress, in a sense, intended, which was make dialysis and kidney care, hopefully including transplantation, widely available. And thanks to the private sector and these dialysis units, they did a wonderful job. If you were to look at what we call the treated rate of kidney failure, immediately the U.S., went to the head of the list in terms of we really were treating all sorts of people with kidney failure, and there wasn't anything comparable in the history where you had the dialysis units fighting to get a particular marketplace. I was called in as a consultant when there was a dialysis unit outside of Gary, Indiana. And it was run by a church outfit or church hospital. And a Chicago dialysis unit wanted to come down and open a unit in downtown Gary, which is at that time was a poor, very largely African-American community. Here, in the very, very origins of the program, you had people fighting to go to places where previously you wouldn't have very much success going to a poor Black community to offer a service. And I'm not sure if we were even aware at that time that kidney failure among Black Americans is 3.5 times that of Caucasian Americans. I was a young, inexperienced person, and I didn't really see all the big picture. I look back, I can see what I did not see. Since then, I've concluded that the independent, for-profit dialysis world simply does not get the credit that they deserve for having really revolutionized this, and in a big way. And especially when you have the comparison group, the economist is asked, how's his wife? And he says, compared to whom? If you compare the success of the dialysis aspect of this kidney failure program with the transplantation side, I mean, there's no question that the transplantation side has failed on so many issues of allocation.
One of the things that I think is interesting is the law created a payment model that encouraged the development of access to care. Now, most of that access to care moved to in-center care, And therefore, some of the areas like home dialysis diminished for a bit. Transplant didn't develop as it could have. Palliative care didn't develop as it could have. But access to care became quite universal with the system. And it strikes me that, and one of the questions I would ask you is, many years later, as we work our way towards the executive order in 2019, we begin to move from access to care being the issue to being choices for patients and broader infrastructure to support care, whether it's home dialysis care, whether it's transplant care, whether it's palliative care. Economically, from an economist's point of view, do you think there was ever a vision of the size that this particular area of medicine was going to consume in our healthcare budget?
At the time that the law was passed in 72, some federal government employees built some kind of a model in which they were aiming at, what is steady state? That means when the number of patients passing and the number of new patients is equal. And so at what point would that be? I guess you would say that at the time, the federal government might have had some concern. This program was fairly liberal in terms of extending coverage. At any rate, their prediction, steady state, would be 25,000 patients. That's how big the ESRD program would grow, 25,000 patients. Needless to say,
they missed that.
There's about 750,000 patients in the Medicare program today. 550,000 of them are on dialysis. It certainly led to a big program, and quite frankly, it was influential around the world. You take like Japan and so forth. Japan was clearly the next largest treatment rate. When I would give talks in Europe, for example, they would be knocking the American healthcare system and the lack of access and all this stuff. And I'd point out, but you know what? Americans have a treatment rate of kidney failure 2 to 3 times what you have right here in this country of yours. The truth is, they're saving a lot of lives and giving access to care to a bunch of people.
It has happened that globally, as our medical office here at Fresenius Medical Care has evolved, we've become much more aware of some of the overt and subtle distinctions between health systems around the world. And clearly the first thing which we've recognized is that the demographics, the Table 1 data of our patient population in the US is very different than our Table 1 demographics of the patient population in Europe. An example would be related to dialysis trials at initiation. It would be related to the number of diabetic patients that are afforded therapy. So selection criteria continues to be very local, in my opinion. And I think clearly the law in 1972 was to try to make it universally available, and I think they did accomplish that.
I think they did it very well, in fact, extremely well. I think that these things are obvious to you and me, but let's say it is not universally known, and it certainly is not recognized that the independent dialysis units have done a wonderful job.
No doubt about that. Our population is quite diverse. But that brings up one of the ties and questions I have for you as you developed and sort of initiated the culture at USRDS back in the day in 1988. Those are really the beginnings of how we began to look at what the baseline statistics were and what we were doing. And it ultimately leads to the questions of, are we able to address issues of equity in healthcare that we're now addressing much more formally, I think. So just describe how your vision of USRDS evolved.
The reason I was kind of central in the beginning of this was I had latched on to working with the Medicare data. There was a large group of nephrologists who were pushing for something like the EDTA in Europe, the European Dialysis and Transplant Association. But above all, they did not want it to be based on these Medicare data. And at the same time, when NIH did make the forward step to fund something like this European operation, you'd be interested to know that the forces within NIH were very strong. There's to be no economic analysis. This is to be a research project on kidney failure, and above all else, no economic analysis, even though they were willing to consider bringing in these Medicare data, which the Medicare data primarily originate from paying bills. There was an eruption in the kidney care community, and NIH got overruled and agreed, well, maybe we would consider some economic analysis, and maybe it could be scientifically valid. Anyway, that was kind of the general tenor of things.
When did they want you to begin adding clinical data? When did that come into the mix?
Medicare data, that's a very loaded word. I mean, all sorts of information. It was very good in many aspects. You had very good records on whether this patient had this lab test and then not having this lab test. But the Medicare data did not collect the clinical results of that test. And that was big absence. But we saw that from the beginning. We actually put 5 or 7 special studies in the field, which were aimed at collecting those clinical data that were missing. The NIH, they run things, they like to have these scientific advisory committees, and they bring all these famous good names together for a meeting and tell us contractors what we're supposed to do and so forth. I made the presentation at the first, it was 6 months into the project that we had launched these studies to complete that clinical data. Everyone stood and gave us a round of applause for having put these things in place. So there was a general recognition of the strengths of the Medicare data, but there was also good recognition of what the shortages and absences there. We were well received because we did put those two pieces together and was a central part of it. One of our studies on adequacy of dialysis, for example, might have been published in 1989 or something. That still gets quoted. I'm absolutely amazed to see.
It does. And, we have spent many, many years studying some of the same measures, physiologic measures of the treatment and the response to the treatment.
I fortunately had a wonderful data processing chief that I'd worked with for over 25 years. He did a very first-class professional job of moving everything in good style, timely, in a fashion that Alan Collins could take over.
It was certainly a big time for the field to recognize that USRDS became the most prominent and exemplar for a country-related registry of kidney disease care. And I think today it still is the representative example. We in our company actually have a population health and medicine team who is doing work to try to help countries that are still looking to develop that kind of USRDS registry function to analyze what's kidney disease care look like in their country. And I think it's modeled after what you started.
Thank you. I think that's true. I mentioned the EDTA a while back, European Dialysis and Transplant Association. But quite frankly, compared to the USRDS, they never had the resources that we had. It wasn't just resources, but there were all sorts of computer developments, for example, occurring at that time, which we happened to have people on our staff who took every advantage of that. But yes, we ultimately, of course, developed the DOPS program, which initially was in 5 countries. We became pretty aware of what different countries had going for them. In the DOPS, they did not even have a census of dialysis units to do our sampling. We literally had to construct a list of all their dialysis units. You'd be shocked at the number of our nephrologists consulting with us would say, I didn't know there was a dialysis unit. And yes, we did set the big norm.
I want to fast forward a little bit and get your views on the impact of the original law has gone through a variety of changes that have led towards value-based care. And the value-based care environment that we live in today is a brand new policy environment in the federal government in the U.S. into how we look at the kidney disease care continuum. It isn't just end-stage kidney disease for dialysis therapy, but it's transplant care, it's palliative care, it's CKD care, it's adequate treatments for early-stage kidney disease. What's your opinion on the current environment of sort of the policy structure since the executive order in 2019?
Well, the ESRD program is a very good example of Medicare for all. And there's all sorts of lessons to be learned from Medicare for all, from taking a close look at the ESRD program. As I recall, the Medicare program wanted to keep you dialysis folks out of the transplant business.
Right.
This is my own personal judgment. It's that somehow they didn't trust you. And so they, quote, were going to make all the decisions and control everything. And you look at the result that's there. I don't know if you've ever heard the term regulatory capture, where fundamentally the people who are supposed to be regulated wind up doing the regulation. There is real economic savings potential from getting a patient off the dialysis therapy to a transplant. And yet, on almost every front, that process has been a failure. And it's been a failure fundamentally in terms of the basic rules, the National Organ Transplantation Act and the law regarding the insurance for the Medicare to patients. It's the biggest failure in the Medicare system.
Yeah.
I wrote an article 30-some years ago that showed that kidney transplants were going to rich white men.
Whether it's a health equity issue or it's an issue of economics, I have said often, I think the best home therapy for end-stage kidney disease is a transplant. And it's a home therapy just like any other home therapy. And it will be interesting to see how the aspect in the evolution of bringing all of these therapies together so that they have some organized and not contradictory set of measures. And we begin to address issues like high organ discard rates, high, unintended consequences of measures of transplant center success that limit waitlisting and other such things. So you have kept yourself involved in a very central area of what I think the future of kidney care looks like in your interests in transplant.
I can honestly say I was dragged out of retirement about 6 years ago by my colleagues and asked to work on this. And I've been fortunate to work with a very good group of people. And I've been really researching this business for 40-some years. I'm shocked at how much I've learned in terms of getting down to the nitty gritty, the typical organ offer to a transplant surgeon goes through 16 iterations before someone accepts that organ.
Yeah, that is a bit of a travesty.
I will say that one of the few first author New England Journal pieces I've ever written years and years ago was on cold time. And that cold time, that is obviously the time the organ is out of a human body, is terrible. And I'm sure this is a big part of this 20% loss rate of organs that are retrieved that do not get placed into a functioning transplant. I'm not sure I've answered you well enough on this notion of value-based care. And I'll be honest, we economists sitting in the background have been hoping for there would be much more integration of the dialysis unit and the transplant center. I personally think the system would benefit, the U.S. system, kidney care. We had a few for-profit transplant centers out there to stir the pot up.
Independent of whether the transplant centers are for-profit or not, I do think bringing transplant care from a bit of the island that it has sat on into the core of how we treat people with kidney failure and sort of their lifetime journey through a variety of therapies. I think that's going to be a critical component of how we look at what we're doing for our population going forward. And there's no question there's high variability in many aspects of transplant care, organ procurement, preservation techniques of deceased donor organs. All of those things can benefit from more research, more investment, a more efficient system than we have. Last question I have for you is just discuss a little bit your thoughts about some of the work that you and Al Roth and others had done to talk about this paired donations system and the sort of concepts of donor chains and so forth. I think that's been one of the most novel and applied ways that economists have directly impacted clinical healthcare that I know of.
I agree, and certainly it has been an honor to be linked in ways to Al Roth, and he certainly earned his Nobel Prize in this arena. And there's no question it may be the only significant change in transplantation in many years. My judgment is the main contributions that come out of it is they've really improved transplantation several ways. One, they're much better able to get a good match between the donor and the recipient. And two, they have made it possible for transplants for people who are particularly active immune systems that it's very hard to match. And so with one of these 50-person chains, for example, there's just a much more option to choose a good match. Al does not like to get into he's big on the notion of how much money is saved. We presented a paper to our symposium. We suggest there's about 45,000 patients a year who die waiting for a transplant. And we propose a cost-benefit solution of how you could obtain a organ for them. At any rate, we not only showed that the benefits are huge to the recipient of the organ, but we also showed that the federal government would save $17 billion a year if they were to move these 40-some thousand patients currently dying with a transplant. So the options for great change there. He has shown that kidney failure is not just a U.S. or a developed world problem. It's a worldwide problem. There's no question this exchange of organs which I think we've been at for at least 10 years, for many people who are very unlikely to get a matched organ, he has given an answer to that problem.
I've been here today talking on this dialogue segment with Professor Philip Held, who led the USRDS from 1988 to 1998 and was here to observe the evolution of the development and maturation of our system of care for end-stage kidney disease. Philip, thanks so much for being here with me and talking with us today.
Thank you. It was my pleasure.